Rounds, Wednesday, April 23rd. First, I'd like to welcome back Dr. Hussein Tarek from ITX Pros. As you know, he has been doing a great job with us on the grand rounds. He just told me that he has 10 cases for us tonight, and we actually turned away almost 10 cases. So this is getting very, very popular, and it's keeping Hussein very busy. So thank you again, Dr. Hussein, for helping us out with this. And
Always a pleasure, sir.
we'll get to the cases in a minute here. We also have Dr. Rick Robinette, our clinical director at the Resnik Implant Institute. Now, again, please ask some questions to Rick. He's a wealth of information either on my lecture or on any of the cases. He's well versed in every aspect of implant dentistry. As you know, I usually go over some interesting or controversial topic in implant dentistry. Today, I'm going to shift the gears a little bit and share with you a very challenging case, one that I believe can lead even a very well experienced clinician down a very slippery slope. By the end of this lecture, I think you'll walk away with some very key points and take home messages that you'll be able to take back to your practice. So what I'd like to talk about is this is a case from one of our doctors from last year, went through our program, and he sent me the case and he wanted a second opinion on it. So let me talk to you about the case, and then we'll actually go through all the different aspects of the case. Here's the case. It's a 45-year-old male, ASA1 hypertension on atenolol. The past dental history is the patient 1 year prior had all their teeth taken out, maxillary and mandibular, with 4 implants on the maxilla, 6 on the mandible. He then had overdentures fabricated on the maxilla and the mandible approximately 6 months ago. The chief complaint, the reason why he went to see our attending doctor, is that the maxillary prosthesis fractured twice, the mandibular fractured 3 times, and there were aesthetic concerns of the existing prostheses. Therefore, our doctor looked at the case and he thought, well, let me just redo the prostheses, but something didn't feel right with them, so he wanted to run it by me. So he sent me the x-ray, gave me all the information, and basically I said, time out, don't do anything. Let's talk about this further. So let's go through this. He was going to redo the upper and the lower. The implants were placed a year ago, prostheses placed 6 months ago. My questions to him were, first, the maxilla. Why did the maxilla actually fracture? What is the reason for that? So my next question to him was it an RP4 or was it an RP5? We know an RP4 is a prosthesis with no palate. We know an RP5 is a prosthesis with the palate. He had stated it is an RP4. As you know from the lectures, when you have 4 implants, that is most commonly an RP5 prosthesis, meaning we need the primary stress-bearing area of the palate to take the stress off of our implants. Therefore, right off the bat, this prosthesis should have been a full palatal prosthesis and not a horseshoe. Secondly, if we look at the restorative space, the restorative space doesn't look like there's significant excess restorative space for an overdenture, a bar, and a hater clip prosthesis. If we look at the attachments, what is concerning about a hater clip? Hater clip is a attachment we used to use many, many years ago. Not so common anymore because this type of attachment is made to basically hinge. It hinges back and forth. It rotates back and forth. Some of the things that I don't like about it, if I look at the design of this bar, we have a hater clip there, small one there, large one in the anterior, small one there, and a cantilever here. Whenever you utilize multiple hater clips and they're in different planes, that does not allow that attachment to rotate. Because it doesn't allow it to rotate, it becomes a fixed prosthesis. So now he has a overdenture. Every time the patient takes it in and out, it's putting a lot of force on those implants. Poor quality of bone, not a good situation long term. If we look at how much restorative space we need, a lot of people will say 12, 14 millimeters for a hater clip. That's actually incorrect. If we look, the tooth needs to be at least 6 millimeters. We need at least 2 millimeters of acrylic to hold the tooth in and to hold the clip and the metal encapsulator in. So we need 6 for the tooth, 2 for the acrylic, at least 2 for the clip and the metal encapsulator. The bar has to be at least 4 millimeters in vertical height. We need at least 1 to 2 millimeters underneath the bar, underneath the bar, so the tissue can have good health. And then we need a sulcus depth of 3. That gives us 18 millimeters. If we look at this case, I don't think, again, we don't have the information where we don't have a CT scan of this or we don't have clinical images. I doubt there's 18 millimeters. So there's definitely compromise in the restorative space. If we look at the ideal attachment, it would have been a breed-in. Why? Because a breed-in has the attachments on the buccal and on the lingual, and they're small like O-rings, so you don't need the vertical height. You could have saved at least 4 or 5 millimeters just by using a breed-in type of attachment. They work out great on the maxilla, and they're extremely retentive. And lastly, on the maxilla, you can see here, there's a cantilever. That's not always good. Usually you get bone loss here. It's only been 6 months since the prosthesis has been in, but I would say in a year, we would probably see some bone loss. Also, if you see the height of the bone, it looks like a lot higher in the posterior than in the anterior. That means that most likely the prosthesis has a reverse occlusal plane or occlusal table. Therefore, that is not good. If we look in the mandible, they put 6 implants and then they placed a bar with locator type of attachments on the bar. So if we look at the restorative space, we need a lot of room when we make a bar and a locator attachment. We're upwards of 19 millimeters in some cases. So you have to be very careful. What ends up happening is the attachments don't have enough acrylic around them, and usually it fractures or the prosthesis fractures. The attachments, if you remember from our lectures on overdentures, versus a independent versus a bar overdenture. In the
If you
mandible,
want to join it now too.
the independent versus a bar, there's no difference in the mandible. In the maxilla, there definitely is. A bar works a lot better, higher success rate, lower failure rate. Therefore, in the mandible, we almost never use a bar, especially with so many implants, and also with a locator attachment. That's just not ideal. If we look at the number of implants, you really don't need 6 implants. Most likely this is going to be an RP4, but certainly you don't need 6 implants for an RP4 on the mandible. What was my recommendation to the doctor? Well, number one, I first said, here's the deal. This patient came in, this prosthesis was done less than a year ago, it was 6 months. Certainly, the patient paid a lot of money for this. The first thing I recommended is refer the patient back to the past clinician who did this. Now, you might think, well, I'm going to lose the patient. 99 out of 100 times, that will never happen. The reason why they're coming to you and getting a second opinion is they don't want to go back to where they came from. However, if you write this in the chart, it looks very, very good. You're not going to be ever accused of over treating or being too aggressive in treating patients. So it looks good if you do refer the patient back. Most likely the patient's going to stay with you, and my recommendation to him was give the patient all the options. One is explantation. Take all the implants out. The other side of point is just redo the prosthetics. However, you don't have enough information to make the rational decision about what treatment options this patient actually has. Therefore, there's some questions that need to be asked. And so I told the doc to go back to the patient and ask these questions. This patient's 45 years old. They've had all their upper and their lower teeth taken out. Why were they taken out? Is it perio? Was there a parafunction attrition? Were they non-restorable? Or is there some underlying medical condition that may have played a role in this? Secondly, what are the patient's expectations? We know that they don't like these prostheses because they fracture. Also, what do they mean by they don't like the aesthetics? Do they show too much teeth? Is their vertical too open? Is it too closed? Whatever. Is it possible that the first doctor they went to just gave them the option of removable prosthesis? Could they want fixed? Give them the advantages and disadvantages of each. One of the big disadvantages of removable in a case like this is maintenance. I mean, look at all the clips, all the locator attachments. This would be a nightmare long term, just replacing those attachments. And longevity, if we look at longevity, certainly fixed is better than removable. And finances, is the patient willing to, if all these implants do have to be taken out, are they willing to do that? Or does another treatment plan have to be come up with, which is maybe in the middle, not taking out the implants, not redoing the prosthesis, but doing something in the middle, which we'll talk about here in a second. If we look at the current condition, what in the maxilla, we have an RP5 prosthesis, which should have been RP5 that was prosthetically treated as an RP4. That was most likely a contributing factor to the fractures. Can this be changed to fixed? Well, probably not. This patient has some parafunction, masseter hypertrophy. 4 implants with a questionable restorative space, probably not. We know that they have parafunction, like I said, so certainly you want to over-engineer those cases if you can. And as I said, with the questionable restorative space, even though we need less space for a fixed than a removable, you have to still make sure that you have enough for fixed. On the mandible, why was there 6 implants? Why a bar? That's really, really over treatment. You really don't need that, certainly for not an overdenture and probably not even for fixed. If we look at the spacing, if you look at removable overdentures, you never want implants closer than 5 millimeters apart. The reason is their attachments then there won't be enough room for the attachments. So we have 2 areas here that the implants are way too close together. So for a removable, that would be a compromise. I don't think there was any ridge reduction. Here is the ridge. Here's most likely where they should have reduced the ridge to, just by eyeballing it for a removable prosthesis. Remember, for removable, you need more room than for a fixed. And then lastly, with this bar, could we be having some flexure problems? We do see it in masseter hypertrophy patients, but look here, look at the bone loss we're seeing here, a little bit here already, and it's only been 6 months. So we may have some mandibular flexure issues, which can be problematic. I told them we have to evaluate the restorative space. So especially here on the mandible. On the maxilla, you could probably put some more implants in, change it to fixed. But on the mandible, these implants may be in a very, very poor position that they can't even be restored with fixed. Also, the aesthetics. Is it vertical dimension? Is it the eccentric? Is it the smile line? What exactly about the aesthetics does a patient not like? Is it phonetics also? So you have to ask all these questions. If you just run in and go ahead and redo the prosthesis, that can lead to, like I said, a very slippery slope. So what went wrong here? Right off the bat, 4 implants on the maxilla, 6 on the mandible. For someone who has parafunction, not good. I think this is upside down. I did that for a reason. This is what should have been done. 6 on the top, 4 on the mandible. Then that would have been a lot more easily, um, prosthetically easier, and also functionally easier. If we look at the osteoplasty, most likely there wasn't one done on the maxilla either, but the mandible is more significant. Why? If we look at the bone here, if you can see the posterior bone, see how the anterior bone is higher than the posterior? That usually means that we have had super eruption of that anterior segment. Because we've had super eruption of that anterior segment, that means we have to really take a significant osteoplasty here to make room for the prosthesis. And then if we look at the cost of this, titanium bars now are extremely expensive. Attachments are expensive. And like I said, with a lot of labs, a fixed monolithic zirconia is actually cheaper than a removable titanium milled bar with all the attachments. So monolithic zirconia might have been the better choice here. However, with that being said, if the patient does want fixed and you look at the current situation, they just need more implants. Most likely bilateral sinus graft. They also need most likely an implant here in the anterior to prevent that anterior cantilever. If they want removable, there's a possibility that you could change the prosthesis to a full palate. That would probably be where I would start. Also, this is my son Christopher's favorite. He likes to change these and makes them with a palatal strap. So you can have a metal-based prosthesis and add a metal palatal strap. This gives you support, so you're not going to be stressing the implants. You'll get the primary stress from the palate, which will take a lot of the force off of those implants. If you look on the mandible, if there is sufficient space and the patient wants fixed, just make a new monolithic zirconia. If there's inadequate space, the only thing you can do is actually remove the implants. If they want removable, sufficient space, make a new prosthesis. If inadequate, which I believe it's highly likely, you're going to be looking at implant removal, or another option on this case is to get rid of the bar superstructure, make these independent locator attachments, see if there's enough restorative space for that, possibly sleep one or two of these implants, the ones that are too close to one another, and that would be an option. Therefore, in summary, what I told the doctor is do not start and make a new prosthesis, because you'll go through a lot of work and you might end up in the same situation that that last clinician had been. It could be that this clinician who fabricated these prostheses did the best they could. Maybe someone else placed these implants and referred them to them. You never know. So never criticize the previous clinician, because you never know what had transpired. If you are going to treat the patient, know that there's limitations on this. Implant number is not correct. Implant position is not correct. Most likely restorative space is compromised. Parafunction is an issue. And there's a past history of losing all their teeth at an early age. Therefore, don't make someone else's problem your problem. If you are going to treat this, document it very, very well. What do I mean by that? Take photos, do multiple consults with the patient, just to make sure that no one can come back at you and say that you overly aggressively treated this patient or you did something that was not ideal. So document all the bad things, especially with the aesthetics and why these fractured, and answer all those questions that I went through. So hopefully you will learn by this is a case that looked like, yes, we'll just redo the prosthesis. I can make a different type of prosthesis, but it's probably not a good idea. So with that being said, if you have any questions on that case, please go ahead and ask Dr. Robinette. We have 10 cases. We're going to get right to this, so go for it. Dr. Hussein, I'm going to switch it back to you, and you can take over
Thank you, Dr.
and do our
Resnik.
first case.
So, first case, Dr. Resnik, is for Dr. Elena Tomasi. Dr. Tomasi, would you mind unmuting yourself, Doc?
Hello?
Hi, Doc. How are you?
Good. How are you, Dr. Resnik?
Good, good. What do you have for us tonight?
Well, I have a single implant case, number 25. I did a socket grafting about 8 months ago. It was a four wall, did with membrane. So I just want to look at the anatomy, the proximity of the anterior alveolar nerve, and
Okay. Okay, good.
review how much
So,
room we have there.
so Doc, do you know, did you extract the tooth or the teeth in this space prior?
Just the tooth. The 30 was a Pontic. It was a long span bridge, 32 through 27. Then it started breaking. We did implant on 28. That was probably done 5 years ago.
Okay. Okay. The reason it looks like a large space, Dr. Hussein, could you
Mhm.
give us a quick measurement on an axial
Oh,
image?
yeah. Patient just want to restore one tooth, number
Okay.
29, and 30, leave it alone.
14.3,
Another
Dr.
thing that
Resnick.
Okay. So at the CEJ, we have 14.3 millimeters. Is that what you're saying?
Yes, sir. That's an affirmative.
Okay. So Doc, um that looks like it is actually enough room for two teeth. Uh so let's 14.3. Usually for 14.3, what did you work this up as, Dr. Hussein?
I added two premolar sized crowns, sir, at the sides of assumingly number 30, just to restore that edentulous site. So I did
Okay.
that two premolar sized crown, Dr. Resnick.
Okay. And did you treatment plan implants in it?
Yes, sir. I did add
Oh,
two Han implants, a 3-5 implant at the side of the ones I'm calling number 29 and number 30, Dr. Resnick.
okay. Can I take a can we see a cross section or a sagittal view of that?
Absolutely, sir. Here you go, Dr. Resnick.
Okay.
3-5 by 10, sir.
Okay, that one looks good. Okay.
And we've
Let
got number 30, a 3-5 by 10 as well, Dr. Resnick.
okay. Now let's go back and look at the 3D image.
You got it, sir.
Okay. So Dr. Tomasi, here's the situation. The patient wants one tooth there. That
Yeah, for
that
now.
yeah, that's 14 and a half
No,
mil.
she just want to leave edentulous space on number 30 and restore 29 for now.
Okay. So remove number 30
You got it, sir.
and okay. And why is that, Doc?
Well, patient had her medical history significant for osteoporosis, and she was on Evenity
Okay.
IV. The last shot was done in 23, so June 2023, almost 2 years ago. She only had two injections, but she had two implants, number 19 and number 20, done in year 2023. And one of them has failed and that was successfully replaced.
Okay.
So she's a little scared. She is 83 years old and she feels like she really doesn't need so many teeth. And so
Okay. So
she figure out for now one is enough. Maybe later on she will add number 30, but now she just wanna try to do 29.
okay. Is 28 is that a virgin tooth or is that a crown on it?
20 is an
28 is an
implant.
implant, sir.
Oh, 28's an implant. Okay. 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 Let me see that Panorex again.
Yes, sir.
Okay. Well, Doc,
Mhm.
did you ever think of possibly, I mean, here's another option. If Dr. Hussein would put that implant distally and just splint it with that anterior implant and get rid of the space. The reason
Mhm.
that I look at that is to put one bicuspid implant in and leave a space
Mhm.
doesn't make a lot of sense to me. I think the patient may not, at 83 years old, may need to be educated more on the ideal situation here.
Mhm.
What Dr. is saying, treatment plan, 2 implants, is actually the ideal treatment plan. But if
Mhm.
the patient's 83 and there is no, just because the patient has osteoporosis, I mean, her other implants are doing fine. I wouldn't even worry about that. The bone
Mhm.
quality there doesn't look bad at all. I
Mhm.
wouldn't be more apt, doc, to put one implant in and just attach it to that anterior implant and close the space. Did you
Mhm.
give any thoughts to that?
No, actually,
Okay.
that I
So
like that idea. Mhm.
yeah. So I'm going to give you a suggestion. Even if the patient, um, if there's a financial issue and it's just charge her the lab fee for the extra 2 crowns or whatever. Yeah, I think your patient would be happier. I think you could sleep at night better.
Mhm.
And it would be, I think it would help that patient masticate better. At 83 years of age, I think that would probably be the best thing. Okay. So what I would do, my recommendation in this case, doc, is go back to the patient, possibly if they can bring a family member in, show them this x-ray or this illustration,
Mhm.
and it just makes a lot of sense to do that versus just putting one bicuspid in. The reason is, doc, you chew more as you go posterior, you're going to chew more efficiently and a
Mhm.
higher biting force. If you have any edentulous site there, that one molar is already shifted already,
Mhm.
and it's just going to continue to shift as she gets older. You never know; she might end up to be 100 years of age. So
Yeah.
I think, but when you do it, he just drew this. Make sure you do a guide plane on that so that you have one path of insertion on that.
Mhm.
Okay.
Okay.
So that's what I would recommend. I think you'll feel better about it, and certainly the patient will be better off. Okay.
Okay. Thank you very much.
Okay. You take care, doc.
You too. Thank you, doctor.
Okay. Second case. Let's go for it.
Next case, Dr. Resnik, is for Dr. Katie Esper Johnson. Dr. Esper Johnson, would you mind unmuting yourself, please, Doc? By the way,
Hello.
Dr. Resnik, this patient does not have any significant medical history, sir. Go ahead, Doc.
Okay. Hi, Katie. How are you?
Hi, Dr. Resnick. Good. How are you?
Good. Okay. What do we have?
Good. So I have a 54-year-old male. Really, the only thing on his medical history is an allergy to penicillin and a history of testicular cancer 20 years ago. Um,
Okay.
we have tooth number 12 that has external resorption and is symptomatic. So I was thinking about taking it out and doing an immediate implant in that site.
Okay. Perfect. And doc, you are coming to module 2, right?
Yes.
Okay. Perfect. Okay. Scroll back and forth.
Yes,
Okay,
sir.
so what I'm looking for, Katie, is Dr. Hussein, show them what I'm looking at, the lingual bone, the apical bone, and the position of the tooth. So right off the bat, if we look at the height, it's very good. The patients maintain buccal and lingual height. Now, if we look at the lingual bone, uh, where, Katie, when your father went through the institute, we used to place the implants right into the socket, and we
Yeah.
had that completely wrong and screwed it up. Now we use all that lingual bone. Show her on the right here, all that lingual bone on the right image,
Yes, sir.
Dr. Hussein. And there's some very good host bone here. And go further apical, keep going apical, and you'll see that there's good bone there all the way up beyond the apex of the implant. Did you plan an implant here, Hussein?
Yes, sir, I did. I did add
Okay.
a 4.3 by 13 millimeter long implant over here, Dr.
Oh,
Resnick.
perfect. Okay. So Katie, see where that is? So
Yeah.
the old way we used to do this is we would go right in that socket and perforate right through the buccal plate. Now
Yeah.
you're going to learn how to do this next month. This will be a breeze. This will be a perfect case. What is it?
Three
What we
millimeters,
look
sir.
for is 2 to 4 millimeters beyond the apex. You have plenty of bone, and it's good bone. This will be no problem at all. So, if
Okay.
you can wait just a couple weeks and do
Yeah.
this one after module 2, I think this will be a slam dunk for you. Very
Yeah.
good case.
He's a teacher, so he wants to wait till the summer. So I think I'll have enough time to do the course, module 2, and
Oh,
then do his
oh,
surgery.
perfect, perfect. So
Do you think,
you'll actually do a lab placing implants like that. So you'll do probably about 6 or 7 of those right in the extraction sites. So it'll
okay,
be very simple for you.
do you think doing this just with a pilot guide?
Yes, you can do a pilot guide, or you can actually, this one would be done freehand very easily.
Okay.
Yeah. So you'll see, but we use a Lindemann drill and you put it right in the socket and it would be very, very simple. So I'll talk to
Okay.
you at module 2 about it, but
Okay.
either way would be good. Yes.
Okay.
Okay.
Perfect.
Any
Thank you.
questions? Any?
Nope.
Okay. Great case.
Thank you, Dr.
Okay.
Resnik.
Let's move forward. Who do we
Yes,
have
sir.
now?
Next case is for Dr. Evan Olson. Dr. Olson, would you mind unmuting yourself, sir, and presenting your case to Dr. Resnick?
Okay,
Dr.
Doc,
Resnick,
what do
I
we have?
think we might be missing Dr. Olson. He's not showing on the participants list. Would you like to go through it, sir, or skip
Oh
to the next
no,
case, Doc?
let's go to the next one and we'll come back on if he makes it on. How's that?
Perfect. Yes, sir. Next case is for Dr. Christina Mangiafico. Dr. Mangiafico, would you mind unmuting yourself, please, and presenting your case? Dr. Resnick, I'm sorry, I stopped sharing my screen. I just wanted to present to you, sir, that for Dr. Mangiafico's case, she's got a significant medical history.
Okay.
Doc, would you mind elaborating more to Dr. Resnick regarding your patient medical history?
Hi, Doc.
Yeah,
How are you?
good. How are you?
Good, good. What do we have?
So my patient, he is, I believe, 54 years old. He has a medical history of Wilms tumor, where they removed his left kidney when he was about 4 years old.
Okay.
So he also had chemotherapy when he was 4. About 11 years ago, he had his colon resected due to the complications with the Wilms tumor that
Okay.
come about later. He also has type 2 diabetes. His A1C is about 6.9, hypothyroidism, and he smokes 1 cigar every Friday following a work week.
Okay. So the Wilms tumor, if that's a tumor, usually it's a congenital tumor in
Yes.
patients. And you said at age 4 he had this
Yes.
removed. So the only in this may have a impact on this when the patient only has one kidney. Remember, the majority of amide anesthetics are metabolized in the liver. However, they're excreted in the kidney. So whenever you have only one kidney, you just have to make sure the patient has adequate kidney function to excrete it, because what happens is you can have active metabolites that last longer in the body. So you have to be careful of anesthetic toxicity. So I would do a medical clearance on this. Also, because the patient is, did you say 6'9"?
Yeah,
Okay.
6.9.
So they're on the upper scale or the higher end of what we like to see, even though that's just a relative contraindication.
Okay.
The other issue is the hypothyroidism. As
Yes.
long as that's controlled, it's fine. As you remember, if it's uncontrolled, that has to deal with the bone metabolism. So T3 and T4, remember, those are the hormones and they
Yep.
regulate bone metabolism. So therefore, if the patient has good kidney function, um, the A1C is below 7 consistently, and the thyroid is regulated, no problems. on this. So anyway, what are we looking at? What are we looking at, upper and lower, or just
Just the
one
upper.
arch?
He
Upper
has
arch?
an existing partial that he wears, and he's unhappy with it. He's
Okay.
not sure if he wants to go to a complete denture or to a complete denture or implant retained denture.
Okay. So let's were you thinking of doing this immediate, Doc?
No.
Okay. Let's just take a look at it. So I'm going to have Dr. Hussein start at the molar and then scroll through
You got
and
it,
go
sir.
ahead, and we will take a look and see how this looks. Okay.
So that's the
So
right side, Dr. Resnik.
okay. So, Doc, what we're looking at is where the teeth are and bone apical to the teeth. And you are 100% correct. There's almost no bone. The angulation's bad. There's pathology. Keep going, keep going, keep going. Yeah, a lot of pathology. Okay. Okay, Doc. So let's go through a treatment plan on this. So here's what I would recommend. Let's go back to the 3D image.
Yes, sir.
And if we could remove the teeth, and then if we could look at an occlusal view. So, Doc, if we look at the patient doesn't know if they want a denture or an implant, overdenture, or a fixed prosthesis, I would still treat it as patient is going to have implants. Therefore, what I would do is take all these teeth out, debride the sockets very well, remove all those infections, and go ahead and do socket preservation.
Yeah.
The reason is it's going to be very, very thin. The patient's going to lose a lot of their host bone. So if you socket graft them, the least you'll maintain a good part of this bone to where they're going to get to do a dry run with an interim prosthesis, usually at least 3 to 4 months before you're going to take a scan on them. So they're going to see if they like the denture. If they do, great. You'll make a complete denture. If not, then you'll go into either removable RP5, RP4, or fixed FP3.
Yes.
Okay. So the key, I believe there's 2 or 3 teeth that have some pathology on them. Dr. Hussein will mark those for you and give you cross sections so you can actually see where that pathology is. Just make sure you go in with a curette, like that Lucas 86 works very good, and curette all that pathology out. And then I would decorticate it, especially right there.
Yeah.
Okay, that one even goes into, is that the nasopalatine or where is that? Is
Um,
that anterior?
that's the lateral. That's the lateral incisor, Dr. Resnik.
Oh, that's the lateral incisor. So it goes all the way through into the lingual plate there. So that's pretty significant. The good news is that site most likely will not be used. So, but
Yeah.
I would still graft it just to maintain the ridge height there.
Okay. What about the thickness? I mean, should I be doing like screws?
No, I think this one is the way I would write this up is phase one would be extraction, socket grafted. 3 to 4 months later, you're going to take a CBCT,
Yep.
evaluate the key implant positions. You may need some additional grafting, but to actually do a GBR at this time, I don't think would be a good idea. The teeth are in too poor of a condition.
Yeah.
The tissue is probably not happy, so there's periodontal pathogens there. I would just let him know that the phase three of this may be bone grafting or bone grafting and implants.
Yes.
Okay.
Okay.
So I would prepare them for that. Yes. Okay.
Yep. Perfect. We're on the same page.
Perfect. Great.
Oh,
Okay. Any other questions? Yes, go for it.
local antibiotic mixed in with the bone.
Definitely on this one. Yes.
Yep.
Yes.
Perfect.
Especially because this patient has had some chemotherapy, even though it's been a long time. They
Yeah.
might be pseudo immunocompromised. So, and that patient, if you look at the dentition, it doesn't look healthy. So
Yeah.
I would say that uh, this would probably be a good patient to start on chlorhexidine 2 weeks before you take out the teeth and lower the bacterial count as much as you can.
Yep. Already got him on there. So
Oh,
perfect.
perfect. Perfect.
Thank you, Joe.
Okay, Doc. Let me know if you have any other questions.
Yes, sir. Appreciate it.
Okay. Okay. Go for it, Dr.
Perfect.
Hussein. Who's the next?
Next case, sir, is for Dr. Bethany Burton. Dr. Bethany, would you mind unmuting yourself, please, Doc? Dr. Resnick, this patient does have a significant medical history, and I want to share that with you, sir. Right now, he's on Forteo and progesterone, but Dr. Bethany, are you on, Doc?
Yes, sir.
Go
Did you
ahead,
say
Doc, please.
male or female?
Female.
Female patient, Doc.
Female. Okay. Yes. Okay. That's right, Doc.
63-year-old
Okay.
female. She's currently on Forteo. She actually left my practice for a period of time and had number 31 extracted with a different doctor. Did not bone graft at the time because she didn't expect to replace the tooth. Now she wants to. She went on Forteo, I think, shortly after or before that extraction, and she was on Avinity for about 10 months before that. So
Okay.
anyways, when I looked at it, it looked tight, and I was considering doing a before trying to place an implant, but I wanted you to look at it and then obviously get your thoughts
Yeah,
on the medical history there.
Bethany, I didn't hear that. Could you say what you wanted to do before the implant?
I was thinking about doing a GBR on it because it's pretty narrow.
Okay. Okay. So first, let's talk about the medical history. Patient
Yes,
has
sir.
osteoporosis. Forteo actually, if you remember, that is a
Relative.
it's a parathyroid, synthetic parathyroid hormone, and that actually doesn't have any issues. It is a relative contraindication, but it doesn't cause osteonecrosis, so you don't have to worry about that. The patient's on what else did you say?
She had a history of being on Avinity before
Okay.
the Forteo. She basically switched because she was going to have this tooth extracted.
Okay.
So she was on it for about 10 months, I think.
Okay, but no longer, just on Forteo.
Correct.
Okay.
Correct.
And what else is the patient on?
Ugh. Dr. Hussein, can you help me out? I know I wrote it down when I was at the office.
Forteo, norteploxine, and progesterone. That's
Or
it. That's the three
tryptophan?
medic.
Okay,
Yeah,
that's an antidepressant, and progesterone, that's
that's
a
it, sir.
steroid hormone. So,
Mhm.
okay, that's most likely from the osteoporosis. Not a problem. That's just relative contraindication. So now, why does this nerve look funny to me here,
So
Dr. Hussein?
unfortunately, the CPCT, Dr. Resnick, didn't include the mandibular canal route. So I just oversized the nerve just to be on the safe side for this one because I can't really visualize the mandibular canal because of the cutoff we've got at the base of the mandible, sir.
Okay, so um, could you remove it and let's take a just a
Absolutely,
quick
sir.
peek at it?
Here we go.
Okay. And how about the panoramic view? Let's,
Yes, sir.
so what, you can't see it at all?
Partially, Dr. Resnick.
Okay. Well, it doesn't look like it's a type 1, so that's good news. I see where the root is. Okay. So you're looking at replace 31.
Yes, sir.
Okay. So the only thing I see right off the bat, that bone level is vertically a
Mhm.
little compromised there.
Mhm.
So, Hussein, what did you put implant here?
So initially, Dr. Resnick, Dr. Burton only asked for one implant, but I thought on adding a second implant and splitting them because of the contralateral, because of the antagonist arch, sir. So yes, I did add two implants, but Dr. Bethany just asked for one implant, sir.
Okay, so let's look at the two and see what it looks like.
Here we go, sir.
Okay,
So
can
that's number 31, Doc.
this is 31. Okay,
A
what is that? An
4.3
8
by 8.
millimeter?
Yes, sir. 4.3 by 8 millimeter long implant, Dr. Resnick.
Okay.
Then
And
I
then
added a
just
second
for the
implant.
sake of me understanding, I know that two implants obviously would be better with just force factors, but what would be kind of the purpose of doing two versus doing like a short fat.
Okay, so go ahead, put the panoramic view on again.
You got it, sir.
So I believe what Dr. Hussein was looking at is if you do take the the posterior implant out.
Here you go, Dr. Resnick. Oh, sorry.
Okay.
Here we go.
So Bethany, what Hussein was looking at is if you put the implant there, that's only going to basically get you the distal part of the first molar and probably a little bit of the mesial, the second molar. If because of the compromised bone. So if you look at how much bone was lost there, you could what you said to me at the very beginning is correct. You could do a GBR and do a larger, wider diameter implant and do one. You won't be able to pick up the entire second molar though. So I believe what Dr. Hussein did, which I like because it is a poor crown implant ratio. Go ahead, put the second one in.
Here you go, sir.
Okay, now go ahead and let me see the cross sections again.
I'm going to start with 31, Dr. Resnick, and I'll take you back, sir, to 32.
Yeah.
So that's a 4.3 by 8, Dr. Resnick, at the side of number
Okay.
31.
Yes.
Then you've got 32, a 4.3 by 8 as well, sir.
Okay. So go back to the panoramic view. So Bethany, I think and I'll speak for Hussein because I know this is what he was thinking, is you could do a GBR. GBRs that's really back there. It's 31.
Yeah,
It'd be very difficult to do. You could actually get by with not a GBR by just placing a second implant. Prosthetically, it would be stronger. Functionally, it would be better. You splint them together and it would take care of the crown to implant ratio issue. If you put one implant, a larger diameter, you're definitely going to have to do a bone graft. And that one implant's going to get beat up back there because the biting force is a lot higher as you go posterior. So with two implants, it would be more predictable. You wouldn't have to wait 4 or 5 months for a bone graft to take effect, which would be a difficult graft, as I said. The reason is go back again to the cross section.
You got it, sir.
Okay. So Bethany, do you remember you did S3, correct?
Yes, sir.
Okay.
Yes, sir.
Do you remember we talked about the slippery slope?
Yeah.
You know that
That is it. Yeah.
that's it right there. So
Yes, sir.
any bone that you put there is
Yeah.
going to be sliding away.
Yeah.
And those are just more difficult, which means you can counteract that by putting more tent screws in. But I tend to like Dr. Hussein's treatment plan because it's faster for the patient. It's biomechanically it's better and it's more predictable. Okay. So if you want, he can work up a single implant for you. We won't do it now, but he can do it later. You'll see that you'll definitely have to have a bone graft though on that.
And then one more question for you, Dr. Resnick. Something I've
Yes.
noticed some local people doing is with these patients that maybe if they were in my office, I would have done a GBR and tried to get a bigger implant in. I've noticed that they'll just put in something smaller, just something shorter that they can fit in the space, especially like with the osteoporosis medications and stuff like that.
Yeah. Yeah.
What is your
Well,
thoughts on that? I mean, because you
well,
want
yeah, you want what's best for the patient. So let's go back to the panoramic view. So if you look at either any of the 3 textbooks, we talk about why we usually don't replace second molars, and there's like 20 reasons. Usually because of the biting force and the available bone. It's not conducive. So meaning if we had a fully edentulous patient, we'd just give them first molar occlusion, and that's usually all patients need. So this is something that is a little atypical on what we would do. But think of this. Take that one implant away,
Right away, sir.
Hussein. Now place that implant that you have a little further distal. So let's give her a molar. Okay. Now look what that does, Bethany. Now you have an anterior cantilever. You have a buccolingual cantilever. and you're going to need a bone graft. So placing that small little implant, there's a reason why natural teeth have two roots back there. In the maxilla, they have three. They take a lot of forces. Those implants just get beat up, and longevity wise, it's not ideal.
Not a good
So
idea. Okay.
yeah, so I would not. If I look at osteoporosis on this patient, as you know, this patient, first of all, is not showing signs of osteoporosis in their jaws. Remember, if they have osteoporosis in the jaws, you won't see any trabecular bone. I see a lot of trabecular bone here. So I don't think it's really affected their mandible at all. And the medication's probably working. And the medication they're on. See all the trabeculi? See
Yes,
how
sir.
you see?
Yep.
Do you remember I've shown you all those x-rays where it's completely black?
Yeah.
That's an osteoporotic
Yeah.
patient or not.
Yeah.
So I'm looking at what is more predictable. I think doing do you remember when we look treatment plan a bone graft, we have that scale 0 to 10. This is probably a 7 or an 8 on difficulty. And I know you can do it. You're a good clinician. However, it's just the patient's anatomy.
Yeah.
That's
No, I
that's
didn't even
one
consider the
one of
two implants. That's
yeah,
a great idea.
that's one of the worst type of grafts to do because you can't keep the graft in place unless you do like a block graft, but they're even more difficult to do back there. So I think the path of least resistance might be what Hussein did there. Also, Hussein, another option would be to make it even easier on her. You possibly could do 2, 3, 5s and treat it like a molar, 2-root molar. Just split them together.
Got it, sir.
That might even be easier because the 4-3 would have to be like right on the money because there's not much margin of error because of the width of bone. Okay, does that make sense?
Yes, sir, and it helps a lot. Thank you very
Yeah,
much.
but if you want, he can work that one implant up for you if you want.
Yes, sir.
Okay.
Thank you.
Okay, take care.
All right, bye-bye.
Okay, let's go. Who do
Ne-
we have next?
Next case, sir, is for Dr. Brittany Holloway. Dr.
Dr.
Holloway, would
Brittany
you mind
Holloway. She
unmuting?
always has some good challenging cases. So what do we have on this one, Brittany?
That's definitely a challenging one, sir. And there's
Oh,
no
it is?
medical history. Yep. We've got some bone defects, but it's a good one, sir. Here we go.
Okay.
Dr. Holloway, are you with us? Could you please unmute yourself?
Can you hear me?
Yes.
Loud and
Hi,
clear,
Doc.
Doc.
How are you?
I'm good, Dr. Resnik. How are you?
Good, good. So what do you have for us tonight?
This is a 55-year-old female. She doesn't have anything significant in her health history.
You never do have an easy case, do you?
I know.
I don't think you've ever shown me an easy case. This is amazing. Okay. So go ahead. I'm sorry. Go ahead.
She wants to focus on the lower left-hand side. She had said that she maybe had those teeth out 4 or 5 years ago, and she said that she did have grafting at that time. She just doesn't really recall. She's
Okay.
also had a couple other teeth on the upper left. I mean, you can have a field day on this case if you'd like, but she's
Okay.
ready also to do an implant, I think, on number 5.
Okay. So let's just look right off the bat here. So we're looking at this patient's missing 20 or 19 and 20, correct?
Yeah,
Okay. And all these other teeth are restorable or they're staying, right? No other teeth are being removed? Meaning
uh,
18 is good?
correct.
Okay. So right off the bat, do you see right in front of the foramen the column of bone you have? That's ideal. So we know that number 20, we can definitely get an implant in there because the nerve isn't going to be an issue. We can place an implant anterior to it. The question is what we're going to have to do posterior. Because as you know, to grow height, vertical height, it definitely can be done, but it's more challenging. So let's
Right.
take a cross section first starting out in 20 and then
20.
move our way back to number 19.
Here you go, Dr. Resnick. So that's number
Okay.
20 area, sir. The
Okay.
width of the ridge is approximately 4 millimeters over here, and we do
Okay.
have the height at this portion, Dr. Resnick. Like,
Yeah, we have unlimited there. So okay. Keep going, keep going, keep going, keep going. That's where it gets challenging. Okay.
Mhm.
Okay.
width of the ridge. Go ahead, sir. Sorry.
Okay. So did you place implants in this?
Yes, sir. So I did follow Dr. Holloway's instruction. She's planning on using an implant, direct implant over here. So what I did, Dr. Resnick, is adding a 6 millimeter long implant at the side of number 19. It's a 4-7, a
Okay.
6 millimeter long implant. And for the side of number 20, sir, I'm using a 4-2 by 11 5 millimeter long implant, sir.
Perfect. Can I see that on the panoramic view?
Right away, sir.
I was questioning whether or not we'd need a GBR.
Yeah, you know what? Hmm. And let me look at the cross section of those two again.
Right away, doc.
Okay. And wow. You know, Brittany, I think you could probably get away without doing a GBR. I think you could just use the burr from your osteotomies and I mean you're
Do a
three
collar graft.
yeah, I mean you're 3 millimeters away from the nerve there. It is a 6 millimeter. However, you do have a nice long one anterior to it. You're going to splint it together. I think you might be all right. Now, you certainly could do a GBR. I think it might be a little overkill. I would
Okay.
I would probably do, you know, what we talked about in at S3 with the little crestal graft after an implant. Um,
Yes.
I think you'll be fine. And that implant could even go even a little bit deeper to where you could probably get even more bone. See how much bone you have on the facial there?
Hmm.
So
Yeah.
you have good 2 millimeters and it's cortical bone. Look how thick that cortical bone is. 2 millimeters of cortical. That's perfect. So you have good primary stability. You would definitely have to splint it to
Okay.
that 6 millimeter implant. And the only thing I would say is let's look at occlusally, who's
You
saying you
got it,
can
sir.
take the implants out if you want. So he can reposition those so they're parallel, but you want a narrow occlusal table on these, minimal cusp height, you know, the implant protected occlusion. So
Right.
make those more bicuspid sized teeth. So, so let me take a look at the actual defect. So let's do a 360 on this 3D image. Okay. So, Brittany, I would probably say this. This is more of a concavity. It would be an easy graft. You have two options. One is to just do a small little GBR just to give you a little bit more width. The second would be to go ahead and do the two implants as he treatment planned, knowing that you would have to do a little crestal graft there. So I think
Okay.
either one of those would be an option, which would be, how old's the patient?
She's 55.
55. Okay. I think either one of those would work fine for you.
Okay.
Okay. So it would be an easy graft either way. Okay. The implant placement, though, just so you know, would be a lot easier if you would do a small little graft there and delay the implant placement. It'll just make the implant placement a little bit easier. However, if you are going to place the implants and do a crestal graft, let him make you a guide so that you can put it in that exact position where all that
Okay.
cortical bone is.
Okay.
Okay.
Sounds great.
Okay. Let me know if you do whatever. Let me see it treatment planned, whatever you decide. Okay.
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 Thank you
Take
very
care.
much. Appreciate it. Thank you.
Okay. Hussein,
Perfect.
let's go. Having fun? Let's go
Next
for
case,
it.
sir, is Dr. Gupta's case. Dr. Mahima Gupta, would you mind unmuting yourself,
Okay.
Dr.
Dr.
Gupta, and
Gupta,
presenting your
how are
case?
you? Is she there?
I think she is, but let me try and unmute her for you, sir. Here.
Hey, Doc.
No, I think we had her, but she might have. She's not present right now, Dr. Resnick.
Okay. Okay. So if she comes back on, we'll come back to her. So let's keep going.
You got it, sir. So, Dr. Maria Benfold, Doc, would you mind please unmuting yourself and presenting your case to Dr. Resnick?
Yes, hi.
Hi, Maria. How are you?
I am wonderful. How is everybody
Good.
doing?
Good. Good. Now,
Good.
what do you have for us tonight?
So mine is not as complicated as Dr. Holloway. I
Okay.
presented a nice, simple, straightforward case.
Okay.
So I have patient Glenn Wasser, age 66, really no big medical concerns. He is on
Okay.
core for cholesterol. On his medical history, he states he has osteopenia, but no medications. I would like to place an implant on number 12. It was extracted. You can see a little bit of the gutta percha remaining from
Okay.
the extraction back in January of 2024. My oral surgeon grafted, was going to place an implant, and then number 19 failed. And I told Glenn to restore the molar first before the premolar because he only wanted to do one. So
Okay.
now he is ready to move forward, which is great timing because I am placing them.
Perfect.
Yes, so I wanted to just, have you take a look and look at the
Okay.
graft. I was thinking 4.3 by 11 uh,
Okay.
and just wanted your thoughts.
Okay. Perfect. So Hussein, let's show everyone. Let's do the 3D image first.
You got it, sir.
So let's see what we have here. And let's look at straight on or lateral view of it so we can see. It looked like, so Maria, see there right off the bat. So we've lost a little bit of the vertical height there.
Yes,
So now, did you say, is this male or female?
a male.
Male. Okay. No parafunction or,
No parafunction. He's just really cavity prone, but other than that, no, he's
okay.
good.
So the only reason this would worry me if we had someone who had significant parafunction to where the crown implant ratio would be non-ideal. But what it sounds like from the looks of his other teeth, I don't think we really have an issue on this one.
Okay.
However, it will be a little bit of a FP2 type of prosthesis. So why I caution you on that is it's just going to be a little bit more elongated than the natural teeth. Now, the majority of males will not even care about that, and most of them don't even show the first bicuspid. So I would first just check the smile line just to make sure he doesn't have a real gummy smile to where he might show that. But it most likely is not a problem. That's just something that I always look at. Secondly, let's go ahead and take a cross section of that where you were, and let's see what it looks like. Okay. So I believe you were right on the money. You said 4.3 by 11.5.
Yes.
Okay. So let's see. Hussein, did you put an implant in here? Okay.
Exactly at
Good.
4.3 by 11.5, sir.
Ah,
Okay.
yeah.
Okay. So see where that gutta perch is? Now,
Yes.
Hussein placed that ideal. So your osteotomy will remove that gutta percha.
Great.
Even if you couldn't remove it, it most likely is not going to be an issue. That's an inert material. On the apical area, it's not going to really cause a problem. But if we can remove it via the osteotomy, that's always the most ideal. So
Perfect.
where that implant is perfect for 3 by 11.5. Maria, this is, and for everyone else on the call tonight, this is the ideal implant if it's going to be your first case. So let's go back to the 3D image, and I'll talk why.
Right away,
The
sir.
reason is this area, you can directly look straight up into that area. Bleeding is almost never a problem. There's always enough bone. You're always anterior to the sinus. And even though that on this patient, the patient has lost horizontal and vertical bone, you can still see there's plenty of bone to place the implant. So this is, and also the other thing is the adjacent roots are diverging. So
Mhm.
you have plenty of room here. So if anyone wants to look for their first best case, this would be it right here. So
This will be my second.
this will be your second. Perfect. This will be, so Marie, on this one, this would be a perfect one, the freehand,
Oh,
to build up
great.
the freehand skills.
Okay.
Uh,
But no
no
pilot
prob,
guide, just go
no,
for it.
exactly.
Okay.
Exactly.
Okay.
Small little flap. And I think it would be, very simple, easy, and you'll get a lot of experience just from this one. Definitely.
Wonderful. And this is similar to one that I am about to do. Do I place because I'm a novice, healing cap where it is extra
Yes. So,
oil? Okay.
so, so that's a good question. When do we do one stage versus two stage? Usually two stage is we bury the implant to have no force on it when we have a compromised primary stability. On this implant, you're not going to have a compromised primary stability. So definitely you can do two stage. The benefit of doing two stage is you can develop the emergence profile while the implant is healing, the soft tissue is healing. Therefore, on this case, I would certainly do a two stage. On your other case, Maria, that
Yes.
is a case that has poorer bone density, and I
Yes.
would make that call at the time of surgery. Once
Okay.
you're inserting the implant, you're going to go by tactile sensation. If you feel that it's very soft bone, which I
It
remember
looks
the
like
bone density on that was not
yes.
that great. That is
E4.
one that you may want to bury just
Okay.
because remember the patient plays with this with their tongue. That's a
Yes.
sheer force, and that's never good. On this one, good bone quality, not a problem at all. I would do it one stage, and it would make everything a lot easier and better.
Wonderful. And I had one more question. I've heard you
Yes.
guys mention S3. Is that module 3?
Yeah. Well, S3 is the old, was the
Okay.
old bone grafting. So module 3 now is the new S3. Yes.
Wonderful. I don't
So,
want to miss
so
out
that
on
is,
anything.
yeah, that is all the bone grafting. So for module 3, there's two main subjects. First is GBR. We teach you how to do all those GBRs. The second part is we teach you how to do all the different sinus grafting, crestal, bumps, and lateral walls.
Wonderful. Thank you so much. I really appreciate your help.
Okay, very good. Good case.
Thank you.
Okay, keep going,
One last
Hussein. One last
one
one.
last
Who do we
case,
have?
sir. Dr. Salama. So, Dr. Mary Salama, would you mind unmuting yourself and presenting your case to Dr. Resnik? Worth mentioning, sir, no significant medical history for this patient, and Dr. Salama is planning on extracting all of the lower dentition, Doc.
Okay. Hi, Mary. How are you?
Hi, Dr. Resnik. How are you?
Good, good. So show me what you have for us tonight.
So
Okay.
the patient is 62 years old. He has nothing significant except he smoke
Okay.
and sometimes drink alcohol.
Okay.
He
So,
wants to keep his natural teeth on the upper arch and have overdenture on the bottom.
okay.
And
So,
financial is a concern.
okay. So you have talked to the patient about removing his teeth and then putting him into an interim prosthesis, then coming back and placing implants.
Correct,
You didn't
because
want
the
to do this
infection.
immediate. Yeah. Okay. Good. Good. So even if there wasn't infection, there's two issues that you talked about. Number one, he smokes, and number two, he drinks. So those you put those two together, that is not always a good combination for immediate implants. So I agree with you. I would take these teeth out, remove the infection, and let this heal. also counsel him on smoking and alcohol use. Now, Mary, I have to tell you, go on to our modules or onto the website. There is a specific smoking consent form and an alcohol consent form that you should have the patient sign. Basically, it just tells them all the bad things that can happen if they do utilize those habits. Okay. So
Okay.
with that being said, you talked about an overdentures. Did you talk to this patient about the two different types of overdentures?
Um, no, I feel like he wants to go the minimal amount of implants. Like he wants
Okay.
to consider three, but I'm gonna tell you, this is my opinion. He has natural teeth on top, so I'm a little bit worried to put only three implants. Um, so I might
I,
try to convince him, even if I do one external charge or two, but the best treatment for him.
okay. So here's what I would do, Mary. So let's go through this case. You write this down. Phase one is you're going to remove these teeth. You're going to debride the area. You're going to wrap the area, decorticate, and you're going to go ahead and do a generalized osteoplasty. The reason is because of the condition of all these teeth, you're going to have to lower and level out the ridge a little bit, just because of all the disease that you have in there. If not, the patient would never be able to wear a prosthesis. Uh, Secondly, you can,
Can I ask a question?
yes, go for it.
Um, so when I do the osteoplasty, like how I how I know I take enough
Yeah,
or not a lot.
okay, so here's what I would do, Mary. I would make this as easy as you can. The easiest time to do the osteoplasty is at the time of the tooth removal. Why is that? Because you're going to have irregular buccal lingual contours, and if you remove it now, it's very, very thin, the bone, and you'll end up using less grafting of the sockets because you're going to lower them. So
Okay.
if you know you're going to do an overdenture, we know that we have to do an aggressive osteoplasty. What I would do on this case is I would have Hussein, can you show us the 3D model on this?
Absolutely, sir.
Okay. Mary, you're not coming to module 2, are you?
I'm
Next
finished.
month?
I finished the all.
Yeah.
It used to be S1 to S5, so I
Yes. Okay.
completed all of them.
Okay. So the reason is we have a new lab that you're going to do, the doctors are going to do this exact procedure. So what Hussein is doing
Is
right
it
now,
next month?
it's next month. So here's what I would do, Mary, on this. I would take the teeth out. I would have Dr. Hussein make you what is called a reduction guide. And it's
Okay.
funny because we just talked about this right before. He just designed it for the lab. But what it is, it's a guide that you put over the bone. And what you do is you just take rongeurs and level it out with the guide. It's like a reduction coping on the bone. So you reduce it. By reducing it, what's going to happen, Mary, is after you graft, when you're going to come back 3 to 4 months from now, after the extractions, the bone is going to be perfect, meaning you're not
Okay.
going to have to do any osteoplasty, and you're going to be able to do 2, 3, 4, 5 implants relatively simple. If you just take out the teeth and you graft the sockets, the ridge is going to be unbelievably irregular. It's going to be very difficult when you go back in to level it off. So if you level it off now, which is what I recommend, it's going to make it easier down the line. Does that make sense?
Yes.
Okay, so you're going to take the teeth out, the bride, wrap it, reduce the bone. He's going to give you a guide to tell you exactly where to do it. Then you're going to close it up and have the patient wear an interim prosthesis.
So
Second,
another
oh, go
question.
ahead.
When I asked the lab to do the interim or temporary denture, should I tell them, specify like how much reduction of bone we're gonna do? So
Yes.
they,
Yes.
okay,
So what I would do is I would have Hussein can actually do the reduction and send you a image of that you can give to the lab. Another way to do it is, did you see where he just measured that? And it was like 14 millimeters or so. I don't know if you saw that. Do you still have that,
no,
Hussein?
I did not see it.
Oh, here it is,
Uh-huh,
right here. Okay, so he could give the lab this right off the bat, and they'll know exactly from where the teeth are what they have to remove.
okay,
So that's another benefit. So that is definitely another benefit that you just asked about of doing it now.
okay,
Okay. And then what you're going to do is wait 3 to 4 months. Phase 2 is you're going to take a CBCT. At the CBCT, then we're going to look at this case again and evaluate 2, 3, 4, 5 implants. Now, Mary, do you remember the two-legged chair analogy?
yes,
So you're going to tell this patient, if you want a two-legged chair, it's going to be 2 implants, three-legged chair, 3 implants. You want a four-legged chair, 4 implants. I like what you said about if you have to add an extra implant in, and even if they just cover the cost of the implant, because 2 implants are never good. They don't work out, especially because this patient has a fixed prosthesis. Also, turn the mandible to the one side or the other.
Yes, sir.
Okay, let's show her the anagonial notch. This
yeah,
patient has very high bite forces. You see that?
yeah,
They've worked.
yeah,
So with that being said, they need more than 2 implants. 2 implants are going to rock, especially against fixed natural teeth or natural teeth opposing it. So therefore, I would definitely, at the minimum, do 3 ACE, and then if the patient wants more a 4-legged chair, then go into 4 implants or possibly 5. Okay.
okay,
Does that
okay.
make sense?
Yes, only like socket graft, no, especially in the interior area. This is where my concern, because I feel the
Yeah.
bone is thin. Do I need to
Yeah.
do it?
So no. So go ahead and scroll through there. It does get thin, but Mary, you're going to remove that top 8 millimeters, and you're going to have plenty of bone. Did you put implants in here?
Yes, sir. I did add
Wait,
implants at the ACE position, Dr. Resnick.
see,
So for the
he already, there you go. Plenty of bone. See, Mary?
Yes.
Okay, let's
Uh,
show her the other ones. Did you, that's C, do A and E.
yes, sir. Here is the E position. I had a 4.3 by 11.5 for limb to long
Plenty of
implant. For
bone?
the A position, sir, a 4.3 by
Yeah.
11.5 with the long implant.
It'll be simple. It'll be very simple. So Mary, let me tell you how easy this could be. If you do the way that protocol that I just told you about, if you do that, what will happen is you could probably do a tissue supported guide to place these 3 implants. Basically, you wouldn't have to make a flap at all. You could just
well, okay.
because you're already doing the osteoplasty at the time of the extraction.
And for when I do the CBT scan after the healing, do I need to do the CBT scan also for the denture? This is my first case of over denture.
Yes.
So,
So here's what I want you to do. Take out the teeth, get a interim prosthesis in 3 months, between 3 and 4 months later. Talk to Dr. Hussein. He will walk you through the whole protocol on how to
okay.
do it. I would suggest do a dual scan on this, and it will make it very simple. Just the fact is, maybe the patient may want a fixed prosthesis, but also if you do a dual scan, you'll be able to determine how much restorative space you need because you'll know where the teeth are. Do you agree with that, Dr. Hussein?
Perfect, sir. Yes,
Yes.
100%.
Okay. Does that make
Okay.
sense, Mary?
Yes, absolutely. Thank you.
Okay. Let us know if you have any questions.
I
Okay.
appreciate you.
Well,
Thank you.
hey, listen, I want to thank everyone. I know it's late. Again, thank you to Dr. Robinette for hanging in there and answering questions. And again, thank you to Dr. Hussein for all the work that you put into this. So,
Thank you, sir. It's always a
thank you
pleasure.
very much. If for the future, this has become so popular. We're getting so many cases. Try to get the cases in earlier. We'll give you we're going to give you more notice on these cases, so that you can get him to, Dr. Hussein earlier. So, okay. Thank you to everyone and have a good night. Take care. Thank you.
Good night, sir.